This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the University of Pennsylvania, published in The Oncologist in 2026. The paper is titled Outcomes After SRS and Ipilimumab plus Nivolumab for Melanoma Brain Metastases Following Prior Immune Checkpoint Inhibitor or Targeted Therapy.
This is a highly relevant topic for our listeners, Alara. In our practice, we're seeing a shifting landscape in how we manage melanoma brain metastases, or MBM. For years, the gold standard was surgical resection or stereotactic radiosurgery, and eventually, the introduction of immunotherapy changed everything. But the clinical question this study tackles is one we face in the multidisciplinary tumor board every week. What happens to the patients who have already been treated?
Exactly, Dr. Eris. We know from landmark trials like Checkmate 204 that the combination of ipilimumab and nivolumab, dual checkpoint inhibition, has high intracranial response rates. But those trials primarily focused on treatment-naive patients. In the real world, many of our patients progress or develop new brain metastases after they've already been on some form of systemic therapy, whether that's a single-agent PD-1 inhibitor or BRAF/MEK targeted therapy.
Right. They aren't the clean cases from the original trials. They've already seen some selective pressure on their tumors. So the authors, led by Dr. Ian Messing and Dr. Emily Lebo, looked specifically at this pre-treated population to see how they fare when they receive SRS concurrently with ipilimumab and nivolumab.
It's a retrospective look, but it addresses a major gap. They were essentially asking, does prior systemic therapy, either immune checkpoint inhibitors, ICI, or targeted therapy, compromise the efficacy of SRS plus Ipi and Nivo, or does it perhaps increase the risks, particularly radiation necrosis?
Let's dive into the methodology. What did the cohort look like?
The study focused on patients with melanoma brain metastases who received SRS and the Ipi-Nivo combination, specifically after they had failed or progressed on previous systemic treatments. For our residents listening, remember that prior ICI usually means they were on something like pembrolizumab or nivolumab monotherapy first. Targeted therapy refers to those with the BRAF V600 mutation who are on BRAF and MEK inhibitors.
And they were looking at several key endpoints. For a neurosurgeon, the most critical ones are local control, meaning did the lesion we zapped stay quiet, and distant brain failure, which is the appearance of new lesions elsewhere in the brain. Of course, overall survival and toxicity are the big picture metrics.
Regarding the results, one of the most striking things is how the prior therapy status influenced outcomes. The study found that even in this pre-treated population, the combination of SRS and Ipi-Nivo remained an effective salvage strategy. However, there are nuances. When we look at patients who had prior ICI exposure versus those who were treatment-naive in earlier studies, the intracranial control rates are still respectable, but these are clearly more challenging cases.
That's an important point for the residents. When a patient progresses on immunotherapy, the tumor biology might be changing. We often talk about cold versus hot tumors. If they failed prior ICI, you might worry that the tumor is intrinsically resistant to checkpoint inhibition. Yet this study suggests that adding SRS can potentially prime the immune system or overcome some of that resistance by releasing neoantigens.
Yes, the synergy between radiation and the dual-agent ICI is the crux of the paper. By using SRS and ipilimumab plus nivolumab, you're hitting the tumor with a physical double whammy and a biological one. The authors focused on the timing, ensuring the SRS was delivered in close proximity to the immunotherapy to maximize that synergistic effect.
Now, let's talk about the elephant in the room for any radiation-based study in melanoma, radiation necrosis, RN. Melanoma is notoriously radioresistant in the classical sense, which is why we use high-dose SRS, but it also has a high propensity for necrosis when combined with immunotherapy. What did Messing and the team find regarding safety?
This is where it gets very interesting for the practicing neurosurgeon. The incidence of symptomatic radiation necrosis in this cohort was a significant focus. The study noted that patients receiving the combination of SRS and Ipi-Nivo, especially after prior therapy, need very close monitoring. While the rates of grade 3 or higher toxicities were comparable to other studies, the combination does carry a risk that requires careful dose planning.
I think that's a key takeaway. When I'm in the basement with the radiation oncologist planning these cases, we're looking at the V12, the volume of brain receiving 12 gray. If a patient is on dual ICI, particularly after failing a prior line, our threshold for concern regarding necrosis goes up. We have to balance the aggressive local control we want with the very real risk of steroid-dependent necrosis that can ruin a patient's quality of life.
And the paper mentions that prior targeted therapy, the BRAF/MEK inhibitors, also plays a role in how we sequence these treatments. If a patient has been on targeted therapy and then moves to SRS plus ipi/nivo, the washout periods and the cumulative effect on the brain's vascularity are factors.
Let's talk about the survival data. In the pre-treatment naive era, the prognosis for MBM was measured in months. What are we seeing here?
The study indicates that overall survival for these patients is significantly extended compared to historical cohorts of patients who failed first-line therapy. Even if they had prior ICI or targeted therapy, the combination of SRS and dual-agent ICI provides a durable response for a subset of patients. It confirms that failing your first systemic treatment isn't the end of the road. SRS plus ipi/nivo can be a very potent second or third line reset for intracranial disease.
For our medical students listening, it's worth noting the terminology, salvage therapy. When we use SRS in this context, we aren't just treating a spot on a scan. We are trying to stabilize the patient's neurological status so they can continue to benefit from systemic therapy. If the brain is out of control, the systemic status doesn't matter. This study reinforces that SRS is a vital partner to the oncologist toolkit.
Exactly. Another point the authors emphasize is the distant brain failure rate. Even with good local control from SRS, these patients often develop new lesions. The ipi/nivo is supposed to provide that micrometastatic coverage. In the pre-treated group, the study observed that distant brain failure still occurs, but the combination treatment seems to mitigate the explosive progression we used to see.
Did the paper touch on the size or number of metastases? Usually these studies have a limit.
The cohort included a variety of presentations, but typically, as with most SRS studies, the lesions were within the treatable range for stereotactic doses. The key was the timing, receiving the ipilimumab and nivolumab within a specific window of the SRS. The synergy is thought to be most potent when the immune system is being stimulated by the ICI, at the same time the radiation is causing cell death and antigen release.
So if you're a resident and you're seeing a patient in the clinic who has been on pembrolizumab for 6 months and a new 1 centimeter cerebellar lesion pops up, what does this study tell you to tell the patient?
It tells you that switching to or adding ipilimumab plus nivolumab in conjunction with SRS is a validated and effective path. It shows that the prior exposure to pembro doesn't make the new lesion immune to the benefits of the dual checkpoint inhibition and radiation. It gives us the evidence to say, we have a plan that can still work.
And for the attendings, it's a reminder to be vigilant about the side effects. More aggressive therapy often means more aggressive inflammation. We have to be ready with the MRI perfusions or even the occasional biopsy to distinguish between tumor progression and radiation necrosis.
That's a great point. The paper highlights that multidisciplinary collaboration between neurosurgery, radiation oncology, and medical oncology is not just a nice to have, but a requirement for managing these complex pre-treated patients. Any final thoughts on the limitations of the study? Like all retrospective studies, there's a degree of selection bias. Patients who are fit enough to receive SRS and dual ICI after failing a first line are already a self-selecting group with a certain level of performance status. But given the year, 2026, and the depth of the data from the University of Pennsylvania team, it's one of the most robust looks we have at this specific population.
Well, this has been an excellent deep dive. The study by Messing et al. Really clarifies the next step for patients who aren't in that initial treatment-naive window. It's about being aggressive, but informed.
Agreed. It's a message of hope for patients with recurrent MBM.
That's all the time we have for today. Thank you, Dr. Alara, for bringing this paper to our attention.
Thank you, Dr. Aris. It was a pleasure.
To our listeners, stay curious and keep honing your surgical and clinical judgment. We'll see you next time on the Neurosurgery Hub podcast.